the first thing I'm going to do is ask who here does not have a healthcare proxy?
Doesn't have what?
A healthcare proxy. This is a form that New York State requires that you have to fill out and have two witnesses sign that gives someone the ability to make healthcare decisions for you if you're unable to do them. So does everyone?
It is required that it be the New York State.
Yes.
It
Yes.
can't be a lawyer's.
That's right.
form.
And there is a New York State form, and I'll give people the instructions on how to get it.
I've been told that.
Yes.
And I thought I understood it
Yeah.
correctly.
And this is something that really I and most people in the medical profession recommend for anyone who's 18 years of age and older, because you never know when you may have some catastrophic injury, catastrophic illness, and you would like to have your wishes of how you wish to be treated when you are unable to make the decision for yourself in the hands of someone that you trust and love. I always think about that young woman in Florida, I can't remember her name, but who had a severe injury, was basically unresponsive, and had no healthcare proxy, was battled over for probably about 15 years as she was being kept alive with Karen Quinlan. Yes, thank you. It was being kept alive with nasogastric feedings and such until she finally expired from an infection. And I don't think any of us wish to be in that position. So we strongly recommend that everyone have a healthcare proxy. The easy way to do this is to get the form from New York State or go to the Office for the Aging and get a copy of the form. You can download it from the New York State Department of Health's website, and that is health.ny.gov. And that will give you, it'll then have a thing where you can get forms and you look under the H and get a healthcare proxy, and you can print that off from online. What I recommend to people, and what a group of friends of mine once did, was we had a healthcare proxy signing party. We all got together and had the friends be our witnesses, so that you had the two witnesses, and then of course you had the person for whom the proxy was meant, and for the person who would be your proxy. So strongly recommend it. Usually don't get them from lawyers. It's better to get it from the health department. And also available from the health department is this little fascinating form, which is a healthcare proxy that you can put in your wallet. So that if you are out somewhere and have a significant problem going on, here's the information. It's the contact information for your healthcare proxy, and something you always ought to have nearby. If you participate in anything at Thompson Hospital, they have this nice little foldable thing, which one of them is the healthcare proxy, and the other part is a list, so you have your list of your medications, your allergies, who your physician is, who you are, who your healthcare proxy is. So I would recommend anyone who is doing anything at Thompson Hospital, see if you can get one of those forms.
I just have a question about the proxy itself.
Yes.
Is it good anywhere, or is it only good in New York State?
Theoretically, they're good anywhere. New York State wishes that it's on the New York State form. And the reason for that is the New York State form requires people to make a decision about artificial hydration and nutrition, which many other states don't. And so what I have done on forms from out of state, I've just put down what their wishes of artificial hydration and nutrition are. That means intravenous fluids, means nasogastric tube or tube through the stomach wall for feeding. So need to discuss all those things with the person you care to be your proxy. It's also a good idea to have more than one proxy. What happens if you and your proxy are in the same car and there's a horrendous accident? It'd be really nice to have children, friends, someone else with, who is also healthcare proxy. So not a bad idea to have 2 or 3. You have the primary proxy, and then you have the in case of proxies. So we really recommend that strongly. Questions about that?
Well, we had healthcare proxies done by a lawyer many, many years ago, so it's probably a good idea.
It's out of date. The addition of the hydration and nutrition was actually done in 2024.
Okay.
So good idea to get it redone. Get it done.
When Sam was born,
Get it done.
35
Get it
years
done
old.
again. And everyone knows where you should have your healthcare proxy at home, do they?
On the refrigerator?
On your refrigerator door. When first responders come to your house, the first thing they're gonna look at is the refrigerator to see if there's anything on the door. And there, it's a good idea to have your own wishes. Do I wish to be resuscitated or not? That's the critical thing, because they're gonna do that right there in your home. Everything else, your healthcare proxy can manage. So, good idea to have this little bit of information in a packet on the door of your refrigerator. And if you have a refrigerator in the basement, that doesn't count. So it's the one that's upstairs.
Where at the Canandaigua Hospital would you get those little?
I would check at the main desk.
At the reception desk?
Yeah, the reception
Okay.
desk, and see if they,
Thank
you
you.
know, that's where the person who supplied these got them.
Okay.
And as I said, there are more of these forms, which I will leave over on the table.
Okay.
Did you?
Go ahead.
He's talking.
Yeah. So we're going to go along the line of other things. Just to step back, the speaker for today was supposed to be an attorney talking about wills and such, and he had an illness in the family, so I'm pinch hitting. So I decided I would do the medical legal things that everyone should know. So the first thing, of course, is the healthcare proxy, and if people have questions about the website, ask me afterwards and I can give you that. Usually, these are also available in your physician's office, so you should be able to get a copy of the New York State healthcare form, or healthcare proxy there. Next form is what's called the MOLST form, and this is medical orders for life-sustaining treatment. These are orders that are generally written in someone who is at high risk of not living for more than about 2 or 3 years. So for most of us, we're under the delusion that we're going to live forever. We don't need one of these at this time, but if you start ailing severely, having significant illnesses, then you sit down with your physician or physician assistant or nurse practitioner, it doesn't matter, and ask to have one of these forms filled out. And they're more detailed. They, again, talk about resuscitation, artificial hydration and nutrition, and a whole variety of issues. And the big thing is, again, in deciding what you want done, this isn't an all or nothing phenomenon. I have had patients, in fact, my favorite story is the patient who had the big family conference, had the do not resuscitate, do not intubate orders all written. There's a guy with bad chronic lung disease. He comes to the emergency room in respiratory distress, and I go up to him. I'm filling in for his physician. I go up to him and I say, you know, Mr. So-and-so, we're going to, you know, I know you have written this form that you don't want to be intubated, but if you're not intubated, you probably won't survive. And so I then said, do you wish to be intubated? And he nodded yes. Go out, walk around for a few seconds, come back, and I asked him a question so that the no answer would also say that he wished to be intubated. And he responded no. Go back, third time come back, ask him the same question, third time, again, he wishes to be intubated. He got intubated. Because I always say if you're there on a cliff hanging by the end of your fingers, you may suddenly change your mind about what you really wish to have done. So these aren't written in stone, they aren't carved in stone. You can be talking about what your general wishes are, but you're always allowed to change your mind. And, you know, my recommendation is you talk to your healthcare proxy and talk about under what situations would you not wish to be resuscitated. And my list includes if I have an illness that I have a very slight chance, only a slight chance of recovering from, then I don't wish to be resuscitated. If I've got a very good chance of recovering from it, and without, you know, terrific disabilities afterwards, then of course I wish to be resuscitated. So those are the, I guess I better turn that on.
I don't feel so bad.
This is
There we
good.
go. That was actually from Wood Library. So the big thing is having a good discussion with who's going to be your proxy about how you would go about this. You know, what sort of things you might want, might not want, etc. So back to the Moltz form. This is the one when you're getting closer to something going wrong. You know, your chance of having a major phenomenon is rapidly approaching. And that's something that's very important to have filled out. When it comes to care in the hospital, most hospitals now have a palliative care physician on staff. I know Thompson Hospital has 3 in their network. What palliative care is designed to do is keep you comfortable. It doesn't mean don't stop. It has nothing to do with the treatment you're getting or stopping the treatment, anything of that sort. It's just being sure that you are comfortable in what's going on. And I found the interesting statistic that I came across was this was a study of patients with end-stage lung cancer. Those who are receiving care with an addition of a palliative care physician actually lived longer than those who were treated just by the oncologist. So palliative care is designed to make you comfortable when you're in severe distress. So I would encourage every family member, everyone to know that there are palliative care docs around who can provide that sort of service. I'm always reminded, we were with my wife's aunt on a trip to the a distant trip to an emergency room. And one of the second physicians to see her was a palliative care physician because she had disease which was potentially, the problem was potentially in stage. And he really made things work very well. So palliative care is something that everyone should know is going on. Then we come to hospice care. Hospice is designed for people in the last 6 months of life. That doesn't mean you have a ticking clock that says, you know, you got to get out, you got to die before 6 months. I had a patient who was on hospice for 2 years. He had a disease which the probability was very high that he would not live 6 months, but went on, survived for 2 years, very comfortable during that period of time. Hospice is a federally funded program. The hospice in this area is the hospice of Ontario and Yates counties, and they can provide service in your home. There are also an interesting phenomenon in the Rochester area that are called comfort care homes. We have one in Canandaigua, there's one in Clifton Springs, there's one in Victor, there's one in Naples. The one in Canandaigua is called Light Hill. These are 2-bed homes that are not federally funded. They're volunteer operated, but they're under the regulations of hospice. And the Hospice of Ontario and Yates County provides patients for these. It's mostly volunteers, some RNs and nurses' aides, and they provide a home care atmosphere in a home rather than in an institution. And I recommend those highly. not only because my wife volunteers at one, but because I'm familiar with the quality of care that the patients and the families get.
Stu,
Yes,
the reason there are 2 beds is when you go up to 4,
yeah,
you come under altogether different regulations.
yes. Anything more than 2 beds, there are now all sorts of federal rules, which make it very expensive and difficult to run. Can't use the volunteers, et cetera. And so when it comes to all these things, again, I recommend the Ontario County or any county that you're in, the Office for the Aging, it's called. The Office for the Aging will be able to give you information on all these resources. There is also a very nice website. It's called compassionandchoice.org. It's all together, small case. This is a not-for-profit which will give you all sorts of information on healthcare proxies, on MOLTS forms, on all the services that are available in your area for end-of-life care.
Does hospice care still require the patient giving up aggressive treatment?
That all depends on how the hospice wants to operate. You are allowed to. Their intent is to keep you comfortable. And if some of the treatments you're getting are designed for comfort rather than longevity, then yes, then you can keep those treatments going. Yeah.
Is there a fee for that? I mean, is there a...
No, the hospice, the comfort care homes are free. They're not covered by insurance. Drugs and such that you're getting, you get those through the hospice service, through the Ontario Yates County Hospice. So those are covered by your insurance, but all the services are provided free.
Even the home care?
Even
hospice?
the home care, if you're at home under hospice, there is probably some other additional fee for some of the home care. But that's where you would check with the Hospice of Ontario and Yates County, or again, the county that you're in. Every county has a hospice service in New York City. Other questions?
What is drugs that the hospice typically?
When does it come into effect? Basically, the recommendation is if your practitioner feels that your lifespan is less than 6 months, that's when hospice is generally involved. I can tell you personally that the average time that people get hospice involved is somewhere between 1 and 2 weeks before dying. Which means that the person doesn't even get a chance to get the care that hospice can provide. They don't get a chance to get the comfort care, pain medication, and anxiety-reducing medications and such that hospice is so good at giving and providing. So unfortunately, people's decisions to saying, oh, I'm at end of life, are often too late to really make that end of life comfortable enough.
As a former hospice chaplain, 9 out of 10 families or patients said that they wish they had enrolled earlier.
Right. And involving in hospice doesn't mean that you have to die.
Right.
In New York City, there is a hospice hospital. They have a graduation rate, and that means people getting out of hospice and able to go back home of 20%. Because often the type of care you get under hospice is such that you improve enough so your appetite comes back and you can eat and you can get up and out of bed and go about life in a reasonably normal fashion. So, committing yourself to hospice doesn't mean at the end of 6 months they're going to take you out and shoot you. It means you're going to get this level of care to make you as comfortable as they possibly can, and that may make you well enough so you can graduate and go back to being at home.
So in your experience, how
I was gonna say, how accurate are physicians in predicting the length of life remaining?
I would say it's probably somewhere between 0 and 5%. All you can tell is that someone has a terminal illness. When they're down to the last week, we're pretty damn good. And so are the people in the hospice care facilities. They know, they have this very strong feeling when patients are about ready to exit. But when it comes down to saying, how many months do you have left? No. My third issue that I'm going to talk about is hospitalization. We talked about that before, and the reason for bringing this up is I have a number of people that I know who have been hospitalized with Parkinson's disease, and at the time of discharge, they are always worse from their Parkinson's than they were before they were admitted to the hospital. So much of Parkinson's treatment involves being physically active, physical therapy, being up and doing things, activities, and often when you're in a hospital, you're almost entirely bed confined, or sitting in a chair, not getting up and roaming the halls or anything of the sort. The other thing is that in Parkinson's disease, the timing of your medicines gets to a point where the timing is absolutely critical, where having a drug taken an hour later than you normally take it can cause a significant deterioration in your symptoms. And hospitals run on hospital time. How do you get the 9 o'clock medicines? There is a nurse with a little wagon and all sorts of trays in it, who is the 9 o'clock nurse. And needless to say, if she's giving medicines to 20 patients, how many of them are going to get them exactly at 9 o'clock? The other problem is not all medicines are equal. If you have, let's say you have levodopa carbidopa as a generic, and you have the brand name of it, they don't necessarily act in your body the same way. And that's with every medicine that has generic equivalents. That doesn't mean those medicines are any worse or better. It means they might get absorbed a little bit differently or get into the bloodstream a little bit differently. And I know when I was a physician at the VA hospital, we were dealing with a drug that they would get a different provider each month for the drug, a different company providing it. And blood levels of the drug were doing this. When they were on brand A, blood levels were too low. When they were on brand B, all of a sudden they were too high. So that in the hospital, you're going to get the hospital's levodopa carbidopa, or the hospital's whatever, any one of the Parkinson's drugs. They may not have the same company of drug that you do. So the strong recommendation is you bring to the hospital a 4-day supply of your medications. And you tell the pharmacy that these are my medications. Often there's a battle. And what I recommend is that the Parkinson's Foundation has a very marvelous hospital guide that gives all the instructions of how you should treat a hospital so that the hospital treats you better. And the Parkinson's Foundation website is very easy. It's parkinson.org. So if you go into that, they will send you free of charge the hospital guide. And over here is a little handout from the Parkinson's Foundation, which is, so you have to go to the hospital. It gives you some very nice instructions, and I would recommend people picking up a copy of that. But I would recommend everyone with Parkinson's, or the care partners taking care of them, that they get the Parkinson Foundation hospital guide, because hospitalization, as I mentioned, is frequently a disaster.
Stu? Bruce had to go in the hospital in mid-May, just before we came back
Right.
to Florida. He's just now getting
Yes.
better.
Yeah, exactly.
He was so weak when
Yes.
he came out of there.
Yeah.
So slow.
Yeah.
But they also have a hospital kit foundation website. Hospital kit that you get, the notes and everything, with the doctor and the nurses.
They try to give you the dose, but it will not.
No, at the foundation, they have a hospital kit they send you,
Yes,
which has all the.
that's right.
Yeah.
They will tell you that, the best thing is to allow the patient to have those medicines at in the bedside table, the bedside drawer, that the patient can then take, or the family member can then give on the patient's schedule. The problem is getting the hospital to agree to that. But that's where you should try to be very forceful.
But they have a kit with all kinds of notes to give the doctor, to give the nurses.
Yes. Yeah, they've got the whole list of things. What you give the doctor, what you give the nurse, and so I really recommend that booklet highly for anyone with Parkinson's disease.
It's all free too.
Yeah. Questions? Now we'll go on to the question and answers. Trish, in her conversations with people, the care partners, has come up with a whole list of questions that have been asked that I will now work on answering. One of them, let's go right in order here. It talked about extended release carbidopa, levodopa. Why are you doing this rather than giving the medicine at frequent intervals? And so I'm going to do a little tutorial on pharmacokinetics, which means how drugs work in the bloodstream. So let's say this is amount of drug and that is time. Generally, when you take a dose of carbidopa levodopa, it gets absorbed, reaches a peak, and then gradually diminishes. Now with Parkinson's disease, the amount of carbidopa or amount of levodopa available varies. When you start with the disease, you have probably about 60% of the carbidopa, the levodopa in your bloodstream that you should, the dopamine that you should have. As the disease progresses, now all of a sudden you need to provide more and more levodopa because there is much less dopamine in the bloodstream. So as you can see, at the start, when you're taking your carbidopa levodopa, you've got a long period of time when it's in the bloodstream. And this little line here is going to be when you have too much. So when you have too much levodopa, carbidopa in the bloodstream, that's when you develop the dyskinesias. You can have severe muscle spasms. You can feel very drugged and knocked out. And so as you can see, when you're at the more advanced stage of needing more of this in the bloodstream, it's a very narrow window of opportunity, and that's why you would like to have a time release form that could raise this baseline up here, so there's this amount in your bloodstream continuously, so you only need to add to that. So that's why you will see the combination. You'll have people taking short-acting levodopa, carbidopa every 3 to 4 hours or 6 hours, depending on where you are in the disease. And then you will take a long-acting form once, twice, 3 times a day to try to maintain this level of levodopa, carbidopa. So you're then adding to it with your more frequent dose. Questions about that?
Maybe I missed it, but if there is this cycle with the standard dosage, why wouldn't everybody be getting the extended release?
Because when you're early on in the disease, low dose, you don't need very much. So you have this now long window of opportunity with these immediate or rapid strength dose that you really don't need the long acting, except perhaps a dose at bedtime to still be around in the morning when you get up.
What's considered a low dose?
That would be something like a 25-100.
25.
Yeah.
Okay.
Yeah. Yeah. And then dose will be increased, and then, the standard routine is dose goes up, time duration shrinks. You will have patients who are taking 2 tablets of the 50, 200 and such every 4 hours, every 3 hours. So the reason you're adding the long-acting form is to try to make it so you can get better control with fewer of these peaks.
What's the dangers of overdosing?
Main danger is just the dyskinesias. If you've ever seen Michael J. Fox, now his is because he had neuroablative surgery, and that left him with the dyskinesias. But what he had were the equivalent of having a levodopa overdose. So this sort of activity, yeah.
I was gonna ask you to talk more about dyskinesias. But anyway, if dyskinesias start, how do you manage them with your dosing when you know you're gonna have this situation that you've been describing?
I mean, as far as, basically what you try doing is and again, it's trial and error. Let me step back a little bit, and because in Parkinson's, as I heard Dick saying, and everyone should know, when you know one Parkinson's patient, you know one Parkinson's patient. Not all Parkinson's disease is alike. There are 2 major classifications. One is the tremor predominant, and the people who present with the standard pill rolling tremor, usually unilateral, then becomes bilateral. Those people respond best to levodopa carbidopa. There is the gait balance variety, and these are the people with the shuffling gait who fall frequently, have a trouble, orienting themselves in space. They don't respond as well to levodopa carbidopa. So, how you go about, first of all, you don't necessarily know whether a tremor predominant patient is going to respond greatly, because again, not all Parkinson's is alike. I know of people who have had the gait disorder who respond very well to levodopa carbidopa, and the people with the tremor predominant who don't respond well to it. So it's a game of trial and error, which is why that's why you want your provider to be someone who's very experienced in Parkinson's disease. And one of the questions was, why a movement disorder unit rather than your neurologist? If your neurologist knows a lot about Parkinson's disease, he or she is just as good as a movement disorder clinic, except the people in the movement disorder clinic also have people used to dealing with Parkinson's, the surgeons, the physicians, the pharmacologists, the physical therapists, the mental health practitioners. So you have a team of people who just have more experience. That doesn't mean your primary or your primary neurologist can't give just as good care. Probably can. A good one who knows Parkinson's, just as good. I know when I was in practice, I practiced in Cortland, New York, so my patients for most complicated things went to Syracuse, except for the patients with Parkinson's, because the neurologists there at that time weren't really very good with Parkinson's, so they all came to Rochester. So you really, you would like to have people who are very familiar with this disease process, because it is so complicated.
So with the ER and the dyskinesia,
Yes.
do you need more ER, or do you need more of the,
Well, the dyskinesia, it means you are having too much dopamine, or too much levodopa at that point.
Okay.
So that's where what I call journaling, or what everyone calls journaling. That's why it's nice to know, let's see, I took my medicine at 3 o'clock. I now have my dyskinesias at 4 o'clock. Okay, that tells me this is that you have reached the peak. I have my dyskinesias at 6 o'clock, and you're taking it at 3 o'clock. Now all of a sudden I have to say, oops, what's going on here? So that's where it's a matter of giving a trial to these medications to see how they're working and adjusting them while you're following the patient and getting their story about how they're doing.
and so the question, the same sort of question.
Yeah.
What changing the the timing of the dosage of ER, or changing
Right.
the timing of the dosage of the immediate release, is the ER one, do you need more of it because you have a dyskinesia or less?
If with extended release, well, first of all, I would look at the timing of when you get the dyskinesia, and if it's a short window, short period, coming on an hour, hour and a half after you take your short-acting dose, then I would reduce the short-acting dose.
Okay.
If the dyskinesias now were occurring in the dark of the night, when all you had on board was your extended release, now I'd start reducing the extended release.
Okay.
Or if they started at, I took my dose at 3 and now here it is at 6, then I would say it's probably the extended release that's the problem.
Thank you.
And that's the whole thing. It's a matter of knowing when people are taking their medicines. Now, it may have been that the reason you have the dyskinesias at 6 o'clock is because you took your 3 o'clock dose with a ham sandwich, and so the levodopa didn't get absorbed as rapidly. Or you have now your small intestine involved with the Parkinson's disease, so it is absorbed more. So the stomach empties more slowly, the small intestine works more slowly, and so now your short-acting is really reaching its peak in a delayed fashion.
You mentioned the ham sandwich. Should you take the drug prior to launch then or after?
Basically, the rule of thumb is 30 minutes before or 2 hours afterwards. The problem, as I mentioned, in Parkinson's is the smooth muscle in the stomach and the intestinal tract eventually gets involved. So you take it 30 minutes before, it may still be in the stomach when you start eating. That's why one of the tricks, I mentioned it over and over again, is you take your short-acting levodopa carbidopa standing up.
Mhm.
You lean to the right because the stomach has a lesser curve and a greater curve, and if you go to the right, it'll slip along the lesser curve much more rapidly and get into the small intestine. And for some people, taking it with orange juice allows it to get into the circulation faster. Not everyone, some people, and something about vitamin C, but that's where.
So it's better to take it before you have.
But it would be better to take it before the meeting, even an hour would even be better.
So what's which drug was that?
That would be the short-acting levodopa carbidopa. Yeah, that's the levodopa is the drug that is interfered with by protein in the intestinal tract. All the others don't make a damn bit of difference.
Okay.
So while we're on that topic, what level of protein is really an issue?
I don't know, obviously if you had a small little piece of cheese, it probably wouldn't make a damn bit of difference. But I don't think I don't think there's any study on that. I certainly haven't come across one. I certainly would not take your levodopa carbidopa with milk.
With what?
With milk.
Because of the protein.
Yeah.
So do they have different names? How do you know the difference between a fast-acting versus the?
They will, the standard, if it's just levodopa carbidopa, that is the fast-acting. But there are several different brand names of the extended release. There is an levodopa carbidopa ER means extended release.
Okay.
Wouldn't your doctor tell you if they were prescribing?
Yes, oh yeah,
So you would know
Yeah.
that.
yeah. But again, when you are timing your medicines, you better darn sure you know the difference between your short-acting and your extended release.
So I'm sort of bothered by what you said, that different manufacturers of the same product have different results.
Yes,
And I think a lot of the times what we get from the pharmacy doesn't even say who the manufacturer.
if you ask the pharmacist, they will tell you the company they get it from. And there are many medicines where the generic and the brand name, the 6 generics that are available for that same chemical are pretty damn close, but there are others where they're not. And so I have seen this over and over again where Person, does fine on the medicine, next month they get a new prescription, all of a sudden it's not working as well. Well, guess what? It's a different company. So one of the things when you are getting your drugs from the pharmacist is you want to be damn sure that you're getting the same product that you've been getting all along.
Yeah, it's interesting because, so my wife's, what she gets, she's had some concern with how brittle it is.
Yes.
And wants to carry it with her, and then, it just crumbles. And
Right.
we've mentioned it to other people, it's like, we don't have that problem.
Right, probably different brand.
It must be.
You would think that the FDA would get involved in assessing standards.
Well, they do set the standards, and the
There must be
the
an awful
standards
lot.
are the amount of active drug in the pill. There is no one does a study on giving patients the drug and measuring blood levels.
The effectiveness of it.
Yeah. All you can say is there is the same amount of drug in that medication.
Stu, an interesting thing that we're talking about right now, because with my current prescription that's sitting at home to be used, came in at 3 different times in 3 different size
Right.
bottles, because they didn't have enough from this particular manufacturer.
Right.
So they gave it so much, and then when they got the second one, they sent the second one along, and they're all nicely labeled.
Right.
But it's
Yes.
complicated.
And that's the whole problem, is you really, and my statement is, I think it really should be for every generic you're taking, you need to know what the manufacturer is, so you get the same one. Because again, they have the same amount of drug, but is it going to behave the same way? You can't guarantee it.
That's interesting, yeah. But what's also interesting, and I'm dealing with Wegmans, and other
Yeah.
pharmacies
Yeah.
probably do the same thing, but they make sure to email me or whatever it is.
Right.
So that I know what's happening.
That's right.
Which is.
Yeah. And the
you're-
pharmacy should really be telling you that it's the same company. Obviously, the best way to know is when you get your new batch of pills, oh my God, they don't look like the old ones.
But don't they usually put it on the bottom?
It's usually there on the bottle, somewhere down on the
It
bottom.
says this doesn't look the same, but
On
it
the-
is.
On the bottom of the label.
Yeah.
So Stu, you said the dopamine level in the bloodstream matters, so why don't they have a blood test that measures the dopamine level?
Because really it's what's in the brain that counts. And really what I'm talking about is the levodopa in the bloodstream, but levodopa gets converted into dopamine in the brain. And of course, there is this nasty thing called the blood-brain barrier that keeps many things from transiting from the bloodstream into the brain. And so just because you have level X in the bloodstream doesn't mean that you have level X in the neurons.
In relation to the carbidopa levodopa, and I sometimes call it Sentiment, which is not what I'm getting, but anyway, it's just to be simplistic. I have a question about the amount, the dosage, and the changes that need to be tweaked if a person is experiencing hallucinations. I've been hearing that our dose is too high, you need this and this and this, so.
Yeah. Hallucinations are a frequent component of more advanced Parkinson's disease. They can be related to an excess amount of levodopa in the bloodstream. Not always, though. Probably most of the time they are related to the disease itself. And that's where the timing of them to the timing of your dose is so critical. And there are many things where the levodopa or any of our medicines can cause this side effect, but also the Parkinson's can cause the same side effect. So that's where journaling, I recommend 2 days out of the week or 1 day out of the week. You write down when you ate, what you ate, when you took your medicines, what you did. I mean, it's a pain in the ass, but that's the only way your neurologist is going to know how you are doing with your treatments.
Is it likely if you're not in advanced stages that you could get hallucinations, and is it often dose related?
And the answer is, yeah, the less advanced your disease, the less likely are that the hallucinations are from the drug or from the disease. But I always say, if it happens in 1 in 100, you're the one.
Well, could changing doses and
Yeah.
change it and then say, oh, they lost medicine
Yeah, I mean, if you're having a dose increase and now you're seeing the hallucinations, guess what? I mean, generally 1 + 1 does equal 2.
then? Or so subtract one and then it
Yeah.
goes away and you're up there.
And so that's where the involvement of the patient is so important in this, because you're the person who's living with this 24 hours a day, and you're the one who knows when you're taking your medicines.
Thank you.
Yeah, and it's really unlike any, you know, I've been doing this for 60 years now. It's unlike any other illness where, you know, everyone responds differently.
Would you recommend if a person skips a dosage, should you take double or just start over again?
If you missed a dose,
Right.
you might take the same amount. If it's within 2 hours, you might take the same amount, and then just be careful. You might delay your followed up dose by an hour, and then try to get back on schedule.
Okay.
You wouldn't want to miss it entirely, or if you're halfway along, you might take half a dose, if you break the pill in half.
Okay.
And again, it's playing games. I know a lot of people who have a smartwatch and they have on it programmed when they take their medicines. I remember we had a lecturer many years ago, and beep, 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 his watch got off, so he said, it went off, it went off just a minute, so we take it. Yeah. The other one was, somebody asked a question about MAO inhibitors. We frequently use drugs that are called monoamine oxidase inhibitors early in the disease. And the reason for that is monoamine oxidase is one of the enzymes that breaks down dopamine. So you're giving these drugs to increase your dopamine level. The person was saying, why do that rather than give me levodopa carbidopa? But this is a nice way to increase your dopamine levels without giving you levodopa carbidopa. And the nice thing about monoamine oxidase inhibitors is they are cheap and they are safe. So that's why early in the disease, we will often use those. In the old days, you would start someone on a monoamine oxidase inhibitor because back then the theory was that if you start levodopa carbidopa too early, it will eventually stop working. That turned out not to be the case, but that was the early teaching. But monoamine oxidase inhibitors, and now there is a combination of an MAO inhibitor and a dopamine agonist, a drug that acts like dopamine but isn't dopamine, together, again, recommended early in the disease to make things easier to manage. And there were a couple of questions about deep brain stimulation. Deep brain stimulation works best for people. Deep brain stimulation basically is implanting electrodes in the part of the brain that has to do with Parkinson's disease and stimulating it electronically. When you get this done, you like to have it done in a center that does a lot of them, as University of Rochester does. The rationale for that is it causes the electricity in that part of the brain acts like dopamine. And you can deliver a current, which is absolutely uniform. You're doing the same current, so you're producing dopamine-like activity continuously. So you can really make your symptoms substantially better. This works best for people who have the tremor predominant Parkinson's, the ones who have responded very well to levodopa carbidopa. We used to delay this process for a bit. Recommendations are now becoming that we started earlier and earlier. have several, at least a couple of members that I know of who had started deep brain stimulation 20 years ago. It's still working. Their disease has progressed and they need to increase the amount of electricity, but they're still getting reasonably good control with the deep brain stimulation. You frequently need to add levodopa carbidopa to deep brain stimulation or other dopamine-like agents to perhaps get even better control, but it is a very successful way to do it. I know one person on my question list who was very hesitant to get deep brain stimulation. I would recommend it highly, get done by people who know what the hell they're doing. I'm sure insurance pays for it, and it gives you really substantial relief from the Parkinson's. But again, works best for the people with the tremor predominant variety. I do know one person who had the balanced variety, and it worked well for him. So, who knows? But generally, for the tremor predominant.
The only other thing is that the battery will need to be replaced, that's in the stimulator.
Yeah.
And the delta time between the replacement of that gets shorter and shorter.
Right.
Yeah. But it does work.
Yeah. 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 The more current you use, the shorter the battery life, so you have to go in for having, and it's put in under the skin. The electrode, of course, goes through the skull and the brain. Little wire comes down underneath the skin, and you have a battery under the skin, very much like a cardiac pacemaker.
And you've got a remote control.
Yeah. Which means you don't go through an MRI. You should not be using a microwave oven. Right.
And they stop you when you want to board a plane.
Right, and they stop you when you want to board a plane. Another question was digestive issues, are they common? I would say they're universal. Dopamine is important for the normal function of the intestinal tract. Constipation will often precede the Parkinson's diagnosis by 20 years. Much of Parkinson's, it appears, starts in the intestinal tract. There are changes, the current thinking is, it may change next week, but the current thinking is that changes in the gut microbiome, the organisms in your intestinal tract, which are actually very important for your nutrition. They break down a lot of things and create a lot of chemicals, which are critical for our survival. But certain ones make it so the membrane of the intestinal tract is a little bit more fragile and things will get absorbed, which then cause the changes in alpha-synuclein in the neurons in the intestinal tract. If you look at neurons in the body, the greatest number of neurons is in the brain. Next most greatest number of neurons is in the gut. And you've got all sorts of nerves in there just waiting to be harmed by things you eat and drink. Good studies showing patients with Parkinson's, the organisms in the intestinal tract are different from people who don't have Parkinson's, but not all Parkinson's patients have the same changes. Depends on what country you live in, your ethnicity, etc., different bacteria will cause the problem. If you take a mouse that has been genetically altered to develop Parkinson's disease and feed them the stool of someone with Parkinson's, they will develop the Parkinson's disease more rapidly. So Parkinson's, the majority of it, there is something like 9% where we don't know what the hell the cause of it is. But 93%, we think it's changes in this alpha-synuclein. And most of those are occurring in the intestinal tract. So constipation is the most common precursor. Diarrhea, usually not. Diarrhea is more often related to the levodopa carbidopa itself or our drugs itself. However, with advanced disease, what happens is the gut becomes so slow that now bacteria start growing where they're not supposed to grow. You're allowed to have bacteria in your colon, you're not allowed to have bacteria in your small intestine. What happens is these people develop bacteria in the small intestine, which end up eating up a variety of nutrients, but also causing diarrhea. So if you have Parkinson's and now all of a sudden you start developing diarrhea, maybe you ought to have it checked out to make sure your intestine is really working normal.
Is there a recommended diet to be on?
The recommended diet is the Mediterranean diet, the Mediterranean style diet that is also recommended to try to prevent heart disease. There are currently a number of studies going on diet alteration in people with Parkinson's to see what effect it has. The other thing that's recommended is fermented type foods. So yogurt, and it has to be yogurt with the active bacteria in it. Sauerkraut, kimchi, which is the Korean form of sauerkraut, kombucha, which is also fermented. Adding fermented things to the diet has some preliminary evidence that suggests it helps people with Parkinson's.
Oh. Any connection with gluten-free diet or celiac disease?
Does not appear to be any relationship.
Would a diet, a gluten-free diet help at all?
Probably not.
Okay.
Yeah.
Talk about fermented food, what about like wine? Would that be in that same group or?
That's not usually listed. Because in the wine, I don't think the active organisms are there.
Okay.
What does wine have effect on did he say wine?
Yeah. Should have none.
Should have, is that a no-no?
I wouldn't say that, but it's nothing in excess. Of course, it's your definition of excess, isn't it?
Sometimes it helps.
Yeah.
You can carry yourself.
Right.
So what about supplementing with probiotics?
Problem with probiotics is not all probiotics are the same, and there have been no studies on which probiotics work. There are studies going on, but at this point, there is nothing that's been well published and well supported that they are beneficial. That's where we're often using natural substances. And different companies have different probiotics. So, but yes, I mean, the logic is there is something there that if you can get your microbiome back to the way it was before you had Parkinson's disease, that might be helpful.
I'm just a little off of it, but can you tell us about the test of, it's not laser, biopsy for diagnosing Parkinson's or Lewy bodies or?
Yeah, basically, again, 93% of people with Parkinson's, it's from the misfolding of the alpha-synuclein molecule. All proteins in the human body have a three-dimensional structure. They have a left-handed structure and they have a right-handed structure. And in the human body, the left-handed structure is generally the one that works. What happens is this alpha-synuclein protein gets misfolded. And the two entry points, the big entry point is felt to be the intestinal tract. The less important entry point is the olfactory nerves that are in the nose, where the sense of smell is, which is why some things like diesel smoke, fine particles from diesel trucks increase your risk of Parkinson's. It's because they're entering in that position. So it's the misfolding of the alpha-synuclein, and there is a test that is now available, been available now for about 2 years and 3 months, where something from your body, initially with spinal fluid, is incubated with artificially produced alpha-synuclein. And If you've got the misfolded protein, it causes that alpha-synuclein to misfold. It's called a alpha-synuclein seed agglomeration test, so that it causes that agglomeration and it precipitates out. So that is now done with a skin biopsy as well, because every single neuron in the body has this going on, and you've got neurons in the skin. So yes, that can be done. There is work going on just a nasal swab to see whether that's going to be good enough. Yeah, and it's a very good study. That's where 93% of people with Parkinson's, that test is positive.
So what about the DAT scan? Is that like?
DAT scan is looking for the amount of dopamine in the brain, and that's pretty good, but it's not absolutely diagnostic.
If it's positive, would that mean?
And positive means you have less dopamine. And again, by the time people are diagnosed, it is down something like somewhere between 40 and 60% of your dopamine production has been lost, which is why we would really like to be able to diagnose this disease a hell of a lot sooner if we're going to do something about it.
And that's actually the nature of my question. If we have diagnostic tools like that, why aren't they being run across everybody that's 50 and older, something like screening for colorectal cancer or something like that?
Colorectal cancer is something you can do something about. We have no prevention. I always use it as an example. I had a patient who had a severe genetic neurologic disease which comes on in your 40s. That's absolutely universally fatal. She had her 14-year-old son tested. It was positive. You can't do anything to prevent it. Have we been given this kid a service or a disservice?
Well, I don't know, it seems like at 50, I would want to know if there.
If there were nothing you could do about it, I think if I had it in my family.
Why are you saying there's nothing to do about it if there are medical treatments and there's
None of the medical treatments to date that are freely available, there are plenty of things that are being worked on, slow the progression of the disease.
But they manage the.
They manage the disease,
They
but
manage the symptoms.
yeah, but why not wait until you have symptoms?
Well, but there's like 100 different symptoms, so, I mean, they're probably having some that you're just not paying attention to.
Right, but if they're not bothersome, would you wish to take a medication for them? I mean, yes, I mean, you can send your genome off to 23andMe, not, of course, they're incorrect, but some other place. And if you have a family history of Parkinson's, you can do that. You can do it to the Michael J. Fox Foundation. And when it's positive, are you going to recommend that your kids get it done? I would think if they were then planning on having children, I would, because by their not having children, they might prevent the transmission of Parkinson's
Yeah, I wasn't
disease.
thinking so much of the genetic, but as the more typical, which is very high percentage are
Yeah,
non-genetic.
the vast majority are non-genetic. Yeah.
So, but there may be symptoms that you may not be associating with Parkinson's. So, I mean, my wife's gave an example. She was having mobility issues. We were seeing a sports medicine doctor because she had issues with her left knee for years.
Right.
Since she was a kid.
Mhm.
So that's what it was being attributed to.
Right.
And eventually that approach didn't get anywhere.
Well, my comment is, my chief of neurology, when I was an intern and a resident, I did six months of neurology. Said a good neurologist can make the diagnosis from the foot of the bed. I think it's probably because your sports medicine person did not have experience with Parkinson's disease and recognized it. I found that in my office, the best diagnostic tool for make the diagnosis was my long corridor. Just watching the patient come down the corridor, they would come in. I was an general internist, so I saw all sorts of patients. I made the diagnosis of Parkinson's very frequently because bicycle findings.
We had also been to a neurologist and got to see a nurse practitioner
Yeah.
instead, and was not diagnosed.
Yeah. And I won't blame the nurse practitioner because another nice study was at least in primary care, the nurse practitioners did a better job than MDs. It all depends on people's experience. I mean, I'll tell you an experience story. My wife had an episode, she was having a little bit of trouble with her hearing. She had an episode where all of a sudden she got this crackling noise in her ear and such, and then lost hearing. So she went to a primary care physician. They said, oh, you have a middle ear infection. And they treated it with antibiotics. Nothing happened. Person then decided I better treat her with steroids because that might help. And got her referred to an ENT person who is very experienced. He said, oh, what you had was shingles. It came down the nerve to the cochlea, and that's what caused the harm. And if I had seen you right away and given you the steroids right away, we would have preserved your hearing. She's lost about 50% of the hearing in that ear because, and if you haven't seen it often, I mean, I just had an experience of someone who had a history of migraine episodes where you get an aura, a visual aura, then lost vision, and found out that something like 30% of people who have migraine with that are at risk to have a stroke and the distribution of the artery to the back part of the brain. Something I never knew before.
I didn't hear the last sentence you said about.
People with visual, the so-called scintillating scotomas that precede migraine will go on for 15 or 20 minutes, and then you have the headache. But a lot of people just get the scintillating scotoma that that starts low and then spreads out in the vision. There is a risk for develop a stroke from that. So if you ever have stroke-like symptoms, that's potentially the risk.
Would blood thinners help in a case like that?
Yeah.
It would.
Yeah. Because, well, no one knows what the mechanism is. We used to think a mechanism was spasm in the artery, but that has been discounted, so we really don't know what that means. But enough of that. Time for some cookies.
Thank you very much.
Thank you.
So Casey, all you know.
No,